Super excited to have Dr. Bess Pierce here for us. Dr. Pierce is starting and running a rehab department at University of Missouri now. She has a PASA waive, and she has a many board certifications, and is super fun, has been super fun to work with and learn from. So from here, I will let Bess take over and give a quick introduction on her background, which goes way beyond University of Missouri.
All right. Well, thank you everybody for joining in. I'm going to try to, my little dog has been in my office all day, and so she is she's ready to work. So she's going to hang with me for a minute here. Hopefully not be too obnoxious. So yeah, I've been at University of Missouri for 2 years now. From way back following a graduation from veterinary college, I actually went into the Army and spent a total of 30 years in the Army Veterinary Corps, 15 on active duty and then 15 on the reserve side. And during that reserve time, I was at Virginia Tech for 10 years, and then Lincoln Memorial University for 10 years, and then landed here when this amazing opportunity opened up here at Missouri to start it. They had a donor that donated to be able to renovate and to start a service. So I was really blessed to come on board to get that going. And so we're growing and kind of moved from the mountains to the middle of Missouri. So I'm the jury's still out on that part, but no, it's actually been really quite wonderful here. So welcome. And I will say, certainly, so I've had the joy of working with Cindy, and we have lots of fun conversation, and I lean on her way more than she leans on me for information and just kind of, batting ideas around and thinking about Shockwave. So my personal goal tonight is to actually get everybody in on the conversation, because as I'm going to laughingly say, if we don't, we've got about 5 minutes to be like, yep. Okay, who's what protocols. So, I'm really interested to hear what everybody does out there, and kind of how, what is your decision-making process. And so really that's what I'm going to talk about, because as we'll figure out, there's not a whole lot of established information. And so it's a little bit of using our best educated ideas on that. So please feel free to jump in, and you should be able to just unmic and talk. I'm totally fine with that. So let me, as usual, see if I can share. All right, good to go?
Yep.
Okay. All right, perfect. One of the things that I thought would be a good idea, and so I know that I am preaching to the choir a bit on this. Let me get one other thing here. Okay, down she goes. But in case we have anybody who's like, I may have one of my students popping on, or if we have any residents in the group, I did include a bit of a review, because I think it's a good idea, or at least to talk about the basic science and to go over that. So I do realize that most everybody, everybody has a Shockwave, most likely, assume that they do, and that you do know the basic science. But I think it paints or builds an important foundation for thinking about protocols. So we'll go, here we go. First is that difference between, kind of focused and radial. And I am curious, kind of a raise of hands. Let me see if I can get my, who all is doing a lot of radial versus focused?
Dr. Bess, we need a little explanation about radial versus focused, if you could.
Okay, we'll absolutely do. I'm going to work my way through some through some other slides here that have a little bit better illustration, because I do think that that's an important thing to realize when you're reading the literature, kind of what that difference is, because it does make a difference in clinical outcomes. That's a fairly clear delineation that has been made at this point. But so it is taking that mechanical stimulus, and through this process of mechanotransduction, taking that physical energy basically at the cellular level and changing that into chemical activity. So that is what kind of rules all of our cells and all of our physiologic processes. So when we, and if we think about all of our modalities, they are some form of energy. It is light energy, it is mechanical energy, and heat energy, whatever that application is, ultrasound, it's going to result in some sort of chemical change at the cellular level. So then, depending on what modality it is and what effect it has with that delivery of energy and that transduction is going to kind of determine our outcome for that modality. So when we look at radial versus focused, and the focused, fortunately, is just that. It is the production of those shock waves that are then brought down to a focused point, depending on the technology of the machine. And we'll talk about piezo specifically here, and Dr. Cindy can certainly jump in on that. But that maximal energy flux comes to a targeted point. It allows you to penetrate a depth varying depending on your standoff, depending on kind of your the actual trode that you have, gives you that depth of penetration. So clearly something like a equine practitioner is going to use a different trode that's going to give them better depth of penetration, whereas we can't use that same one on that little some of the finest treatments that we do are in bones for fractures and raptors, believe it or not. And so, that's one that I need a very, very small trode and a very controlled amount of energy that I'm going to be able to deliver to that point. But bottom line, again, focus allows you to deliver energy to that targeted cell. So you're going to get that penetration, and you can kind of see here that we're going to get that down to the muscle or bone level, whereas radial is more properly called pressure wave. And it is going to spread out at basically the skin to just below the skin surface, and the maximum energy flux is going to be up by the source rather than at the target. So we really look at radial, and I think this is where some of the where we don't see the clinical effect that we have been looking for, or that we expected, is that it's a different delivery of energy. And so I think we've probably been having the inappropriate expectations of radial when we have treated some of these conditions. And so I think we'll start to see that kind of separate out into the literature, but there is a distinct difference between those two. And so it will be actually a different trode. Your focused shockwave trode does not deliver your radial energy. And so there are some of the machines that you have, and correct me, Cindy, that there is not radial. This machine does not, the piezo does not do radial, or is there a separate trode for that, or a separate attachment for that?
We don't sell
Okay.
radial attachment. I think one of the things I like to stress with radial is it is a pneumatic device. So it's kind of
Exactly.
Yeah.
Right, exactly. And so again, it's more like a pressure wave. And so there's some thoughts that it might have some myofascial benefit, but we're just going to kind of leave radial, off the, kind of push it over to the side. And you can sort of look into that if you're interested in that aspect, but really focusing, no pun intended, on shockwave, focused shockwave. And of course, there are several sources. We are mainly, talking about the piezo source that is a series of crystals that are arrayed so that you get this focus down to a pretty fine point. And this is one of the things that Cindy and I talked about a lot, is that one of the critiques that has been thrown out about the piezo is that it's too precise, that it's too small, you don't hit a larger area. And That is true, and that to me is the strong point of it, is you need to deliver that energy to a specific area. You're not This is not sort of a shotgun type treatment, and so, it does allow you to be very precise with your placement, and that's actually one of the big advantages to it. I have actually used all of these. I am not here to sell piezo in particular, but, they each have their pros and cons, and just, be aware of that. I assume that we're all either looking at piezos or that we're going to or already have them. So again, we will kind of stay down that pathway. But the thing that I like about it so much is that it is precise. Get rid of this here. And so this is kind of a good illustration. I can't remember this. I think this came off of the piezo website, but I love the illustration in that. Of course, we've got the trode. We have the array of crystals that then produce the eventually focus that shockwave that is produced. We've got our standoff pad that is going to help us get to that penetration that we're looking at, depending on the trode that you have. Can be up to for like the small animal, up to about 80 millimeters, 8 centimeters. But you can see this really fine area, or fairly small area of focus here, in which you get that positive, that initial pulse wave that is a very high pressure. I had to remind myself, so megapascals, the MPa is megapascals, and that is actually the pressure of about 100 metric tons resting on an area of 1 square meter. That's a lot of pressure. Now, the thing is it's nanoseconds wide, so very, very brief. And usually what we see in these is that the illustration is actually a higher peak in pressure. And so it's taller, but not as wide here. So this gives you the impression that it may be wider than what you imagine, but this is only nanoseconds wide for the peak pressure. And then a little milliseconds out here creates this sort of vacuum in the tissue in this negative pressure density, or negative pressure kind of cavitation, mechanical cavitation. And actually the thought is, or at least in some of the studies or background, is that it's that negative portion, this negative energy density, that is this cavitation, that is responsible for a lot of the biologic effects. So and again, that Cindy and I have these fun conversations. Well, I think they're fun because we're both geeks. So so Cindy, I don't know if you all have looked at that as a company, specifically that area, or if you have any comments on that kind of that negative pressure wave that occurs. What are your thoughts on that as far as the efficacy?
So I think the negative pressure wave is very, very important, because if you just push and you don't pull back at all, nothing moves, right?
Right.
Cavitation is a tricky one, and it really depends on what you're looking at. The hard thing with cavitation itself is, does it occur in biologic tissue?
Correct.
I do see it in water. I mean, we will play with this trode and put it in a glass of water and watch it, which is kind of a fun exercise. But definitely, I always think that the positive and negative is very important. Mechanical transduction, yes.
Because it is actually that, again, that kind of mechanical movement of the tissue and the stretch and the again, the energy that is delivered, that does create eventually that biological effect, down the road. And so really, when we start thinking about delivery, which then leads to protocols, we have to consider that, both the kind of time, intensity, and total energy delivery to that tissue. So those are going to be, so I think it's important to, kind of, sometimes we don't look at the nuts and bolts of, we have a general idea. But I think this is a great visual to kind of show you that area where we get that negative energy, and then that very, very focused point here. And so, again, it's considered, piezo is probably considered to be the lowest intensity of the shockwave, but I like to think of that more as the precise, not so much low intensity, but precise. Things that we look at as far as moving into, what effects do we have? So we know, and when we talk about protocols, the challenge is taking what is really good basic science, and we see this with many of our modalities. Like the science is there I'm convinced in all the reading and looking, the science is there for shockwave, the science is there for laser, the science is there for ultrasound. It's really translating it into clinical protocols is where I think we're in that kind of gray zone right now, because we just don't historically have that many studies, good controlled, randomly controlled trials, good studies. But it's getting there. We are starting to see some of the things, and I've got some later in the slides here for that. But and we're pretty familiar with this. Kind of the biological outcome, the angiogenesis, that increase in circulation. And that's where it really is a very strong point for our tendon and our tendinopathies, because we have such avascular environment in those tendons that they don't heal, period. They just stop. When they're injured, there's very little. If left alone, there's very little healing that can occur, mostly because of the lack of blood supply. And so that angiogenesis is a really, really critical point for that. And then, of course, cell proliferation, it upregulates that, the tendon cells, it upregulates muscle myocytes, to actually, as sort of that second stage of healing and laying down new tissue. Collagen upregulates normal collagen. The inflammatory response helps to moderate that. And I've got this kind of in several different forms to just kind of build the story of the effects. And again, I also put this in case we do have any residents or anybody that's studying for bigger, badder, they have to regurgitate this slide. So there will be a quiz afterwards, and it's so this kind of stuff makes me fan myself. But I think it's amazing that we have gotten to this point in the basic science where we know these really complex pathways, through different receptors and these, so here's our nitric oxide. We've got our just a whole host. We've got our calcium modulation. Sorry, I have to keep going back and forth. Let me go over here. There we go. So part of my slides are covered by the bar. We affect our ATP. We have VEGF. We've got so again, that delivery has all of this really, really complex biological effect in the long run, which ultimately ends up with transcription and that activation of stem cells, tissue regeneration. So this is where again we see a lot of our this is our very complex slide. And it just, there are so many of these. If you really delve into the literature, there are incredible complexity for what we have kind of discovered along this line here. So bringing it to the, to more the tissue level. I'm so sorry, guys. Give me just a second. Let me see if I can find a place for this bar to go that is out of the way. Okay, maybe that. Because we do a lot of tendinopathies have been, classically the thing that we have treated with our shockwave. It kind of evolved from ultrasound has much of a therapeutic ultrasound has much of the same effect at the tissue level. It's just that we can't get that same energy. We can't get that same, this is kind of better, faster. For shockwave. So, but a lot of these same things happen. So again, just another way to look at it, that nitric oxide that causes neovascularization, control of inflammation between our interleukin group and then macrophages. So it effect on all of this. So then it does the idea of bring those growth factors in there and upregulate that stem cell production, and then eventually maturation into healthier tissue. A reorganization of healthier tissue. This is one of the things that I love is that we actually see so much more from in our analgesic effect and using this for analgesic management. And that's where we've kind of branched out into, looking at this for lumbosacral pain management, for arthritic joint pain management. Is that because we have, again, these biological effects that let us, everything from inflammatory mediators like substance P, also has a direct effect on nerve fibers, our calcium balance within the cell or influx within the cell. And so I personally use it probably as much, and I'm very curious. Again, I'll kind of pause and people jump in, for how much you're using it for just straight pain management versus, say tendinopathies.
I have had great results with bicep tendinopathies. And my protocol, I did it 1 week apart.
Mhm.
Okay, my treatments. And it was diagnosed by musculoskeletal ultrasound. So
Mhm.
I had a good diagnosis. Okay.
Mhm.
And but it wasn't totally torn. It was
Right.
just a strain, like a moderate to severe bicep tendon strain.
Mhm. Mhm.
And 6 treatments. And I did around 800 to 1,000 shocks per treatment. And then I lasered over it.
Okay.
And I was planning to take the dog. Well, the dog had an appointment with a specialist, but it took so long to get that appointment. But by the time he had the appointment, the specialist even said, "Well, he's better,
Yeah.
he doesn't need to see me."
Right. Right.
So that was my experience, and I've used it on suspected tendinopathies since, but maybe not having such a specific diagnosis, because a lot of times people don't want to go and we're just diagnosing by palpation.
Right. Sure.
Does that
Sure.
make sense?
Yeah. Oh, absolutely. Absolutely.
Here, Dr. Bess, I
Mhm.
think we're seeing a lot of pain relief in our senior dogs, right? In
Right.
our senior population, whether it's LS
Yeah.
pain relief, or OA pain relief. And
Yeah.
that's super important.
And yeah, we use it as one of our primary tools for, for hip joints, elbow joints,
Yeah.
well, just about everything.
Yeah.
Yeah, I do think that we get a good response. And I wonder too, and this is me, I'll try to make it very clear when this is me speculating versus, what is out there in the literature. I, I have to believe that because of the tissue effect that we do get some remodeling of the synovium, which does help in that process of, of course, what we need are histopathology and all, studies and all of these. But I just, I do think we get some remodeling of the synovium so that we just calm down that synovium, which is what is so inflamed and so hyperplastic and prolific in that arthritic joint. And so I think that that's a large, at least a decent amount of the effect that we get. Again, my speculation on that.
I agree. I want to study it. Yes.
Yeah, yeah, yeah.
I just need
And
$1
all of
million.
I know exactly, and just put it on our list of studies we're going to get to. Tissue repair effect. We've talked about a lot of this, but again, a lot of it kind of centers around two things: is that neovascularization, and then the upregulation of stem cells, and then differentiation, through growth factors and that maturation and collagen production that occurs. Osteogenic effect. We haven't touched on that yet, but this is actually where Shockwave kind of started. Tendon work was a big part of it, but it was actually most of it was for bone healing, because it does have an osteogenic effect, and is and that is well known. And so we do everything. We've done feet, where you have a fractured P2, and those things don't heal worth a darn, just because there's so much pressure. And not, these are, an agility dog, and, increased, or had that, and the surgeons are always amazed. And I'm like, send them to us sooner than later, let us treat them. And so we actually treat a fair number for, malunions, for just delayed union, those types of, And so again, I think because of some of the same thing, that nitric oxide, that increased circulation upregulates, you can see this, that we actually have an effect on the vitamin D and signaling pathway, and then decreases that osteoclastic activity and builds that osteogenic capacity.
So Dr. Bess,
Mm-hmm.
Dr. McKee has a question about large bone bruises and any type of protocol that you've had for bruising?
So I don't have a specific, I don't have a specific protocol, and I would say I would be willing to use that one a little. I don't use shockwave for acute like trauma or any, so I would use it later in the process, because it does have the potential to, especially if you're using those higher, millijoules per millimeter square, your energy level, you actually can cause some discomfort, petechia, bruising, and so there have been, in my review, I did not find studies specifically for bone bruising, and so there are some, there's some indication for trauma, for musculoskeletal soft tissue pain, and acute and chronic pain, but I don't use it in immediate trauma type. Anybody else, do that? Cindy, you're.
We do some, but again, we're down at the 0.03 to 0.06 millijoules per millimeter square.
Right. Super low
in
intensity.
In
Yeah.
my case, in this case,
Uh-huh.
I haven't wanted to interrupt because I have so many questions and this all seems so over my
Sure.
head. I personally have, based on my MRI, I have a large bone bruise in my tibia because I have no cartilage in my knee.
Mhm.
So thinking about using myself as the guinea pig before I try a patient, I just wasn't sure, is this going to fracture my bone, or is it going to cause more of a lay down, or
No.
what is it actually? Because it's not comfortable, but I wanted to know, is this actually going to help and how long? And this has been a very old injury.
So
Right.
I did my tibia after doing my cruciate, and when you do your cruciate, you create a very traumatic bone bruise if it's and if you do it super low to less than tolerance, all you need to do is feel the energy for it to stimulate any type of, all you're really doing is angiogenesis and the minor, you're not moving the bone itself, you're bringing in the healing factors from the blood flow and stuff, in my opinion. Of course, we don't have science data on that. But you're not going to hurt your bone, especially if you don't sedate yourself.
Right, exactly. Yes, please don't do that. Don't go there. No, but those the subchondral, and I would argue a little bit that the subchondral bruising that occurs because of that lack of cartilage is actually a little bit different from a hit by car traumatic bone bruise, and so it's a little bit different process, and so no, I would actually feel very comfortable using it in that situation, versus in a more trauma type, like I said, hit by car, kind of situation.
I have another question, because even in the few slides you've gone over so far, and of course it keeps coming up that it's anti-inflammatory, and that's what we learn in the rehab course. Recently, I came across some type of paper. I don't even know if I should call it a paper, but it was it described shockwave versus laser as shockwave is pro-inflammatory to help heal, and the K laser or companion laser is anti-inflammatory. So then I thought, well, here I've had this patient forever that I've been doing both, because I'll have one day maybe I'll do shockwave, and then right after that my staff will do laser, or maybe we should do different days. So now I'm like, oh, am I counteracting what we're doing?
Right. So the thing that's actually, in the early days of a shockwave, number one, we use much higher when you're hitting at that 0.4, 0.5 millijoules per millimeter square. That can be absolutely broke, because it creates kind of micro trauma, and so that absolutely can be inflammatory. And it used to, again, Cindy and I've had this conversation many times, that we used to say we had to incite this inflammatory response in order to promote healing. We actually do not. If we kind of go back to those, those various receptors, and these are pathways that are not, we're not inside, like we're influencing calcium influx, we're causing, or we're influencing nitric oxide release, we're actually down regulating some inflammatory mediators if we use a high enough protocol, we actually could incite. So it's this balance and we've kind of gone away from that theory of that we have to create inflammation in order to, in order to promote healing, because it's really not about that. It's actually about all of these very complex pathways that don't require that.
Okay, so it's okay and maybe even beneficial to do both.
Potentially so. It again, we don't have, unfortunately,
I know,
we
it's
don't
also
have
new.
the,
Yeah.
Well, I do it on myself all the time. And I have a torn meniscus, and I shocked one day I shocked the heck out of my knee, and it was kind of sore. And I thought, well, how am I going to get through this work day? And I lasered over it, and I could not believe the relief I got. I feel it's a good combination. I do use it. But I will cut the laser treatment in half. And again, I'm flying by the seat of my pants here, but I'm experimenting on myself.
Right. It's and so probably in that case, quite truthfully, if you did I'll just call it a heavy protocol, you actually probably did counteract those two, that you did have some inflammation, which can start to promote some healing kind of through a more actually delayed pathway, but your laser probably helps relieve that a little bit.
And
you
it
have
calmed it down.
Yeah. Sure.
Can you start with the laser and then do the shock though?
So
I usually do shock first.
Yeah. Yep. And you got to remember, you're hitting two different tissue planes with your laser and shockwave. You just, you have to keep that in mind. So you're probably, with your laser, you're getting more, I don't want to go too far down this path because I do want to talk protocols and stuff. But you are, 96 to 97% of your photobiomodulation, your laser beam is attenuated at the surface level. And so it's not to say that it doesn't have effect, but it has very much. That's why it is so good for epithelialization and wound management, because most of that action happens at the surface level. Now, where you do get some pain management is because of the nerve endings that are in that surface level. So you're kind of balancing. Yeah. So you're really kind of hitting two different things. And that's why I think it can be synergistic. But you got to remember, you got to think about your laser appropriately. So that can be another.
I think everybody on here is small animal.
No, there's a combination. There's a combo.
Okay.
Yep.
Okay.
Yep.
Okay.
So yeah. But great thoughts, and so I just, thinking about, but again, looking at that, the different basic science of it can help you in the absence of protocols and studies that we desperately need, can help us kind of think our way through this. So here, and of course, we have this, and it just, the list is getting longer and longer. Some of them we have good evidence for. I have starred those, put little asterisks here. We have very, very good, solid, high level evidence for these three. We have some decent evidence for some of the other ones. We are getting a lot more evidence for pain management, for especially on the human side. And I am going to kind of drill down on the human side here in a minute, because they have led the way, for us. So outside of the US, so in Europe, outside the US, I should say. And I suspect that we're all kind of using some combination of this with our shockwave.
What about PRP injections?
Yeah. So again, very little. The one study that we do have was on the shoulder tendinopathy. So bicipital tendinopathy, and they looked at kind of three groups. So PRP alone, shockwave alone, and then PRP plus shockwave. And this is one of the ones that we have one of our shoulder protocols that actually has been studied. And that was, the one treatment every 3 weeks for 3 treatments was in this particular study. They found that shockwave alone and shockwave plus PRP had had a better effect. Those two were equal, but had a better effect than PRP alone. So that was kind of the first finding. Yeah. And then the fact that those two, that it treated it as well, shockwave alone. There is always some risk, and they have shown this with looking at some early work in PRP, well, both bicipital tendons and cruciates, that a certain number of them will go on to rupture. particularly if you have large areas of dropout. So missing fibers, and because that's what we do, is we do the core lesions, right? And equine folks, jump in. This is your place. You guys are the masters at at injecting core lesions. So, but in small animals, we'll see a certain number of those go on to rupture. And so my personal thought is, I use shockwave first. If I can put the shockwave, so to speak, on it, so if I've got a tendon that is accessible, does not work with CCLs. If anybody's got a great, magic wand for craniocruciates, share it, please. But if you can otherwise put the shockwave on it, then you have a very good chance. The evidence is very high for healing tendinopathies. Even now, if you're pushing towards a 3, if you're a high grade 2, everybody's going to struggle with that one. But otherwise, you have a very good. And my thought is, why even chance injecting them when you get just as good a response, at least in some of the tendons that we've seen.
Okay.
May I?
Absolutely, please.
Okay, and then I'll shut up because I've been jumping off my seat here because I mean, like, I could not be happier with my, my machine and everything. And so what I'm doing is like, it's Prostride. So it's kind of like a mixture of IRAP with a PRP, putting it in, and I'm doing a half shot, like half of what I would normally. It stimulates all of the growth factors and everything. I'm having hands down the best results. So I just can't say enough good things about the shockwave machine. So I'm done.
So is this in your equine patients or in small? Yes. Okay.
Like absolutely. High dispensaries, look, So that's why I was asking how many on here were small animals, because the high dispensaries seem to be sort of a big deal with the racehorses, and we won't even get into HISA. We're not going to go there. So
sure.
Okay,
sure.
but anyway, I'm putting the Prostride Alpha 2s in, okay, first, and then I'm just doing a half shock to stimulate. And I'm telling you what, it's really, really good.
I think a lot of what we have to dig into, and we don't know enough of, if I can kind of interject, is the amount of energy that people are putting in along with the PRP.
Right, exactly. I mean, in the bottom line, I agree. The bottom line is that we need studies. We need better studies, because I do think that they can be synergistic. But I think it's also, like I said, maybe these really high energy treatments. Yep.
The half.
Right.
Not going full blast. Yeah.
Yeah. So do you stay down at 0.1, 0.2? Because I know the equine protocols are really high intensity protocols.
Well, okay, we're going to be at about 10 to 12 for 400.
Okay.
I need my chart, because you have a different.
I have a different one. I have this special one.
Right. Yeah. You are going to have
I had the one when
she's at close to 0.2 millijoules.
Okay.
But many less pulses. And how
to go with the SID.
Yep.
I don't know how to balance it at this point.
Okay.
This probably does not apply. This is to dogs, cats, or anything like that. So,
well, and I think it's probably just an intensity energy level delivery is what it comes down to. So it may be that we find that combined with 0.03, 04, 05, these very, very low intensities, maybe the ticket to it. We just have not seen those studies. And at the more traditional higher, not high intensity like what we see in equine, but the 0.2, 0.3, those went on to have some issues in small animal. And I think it's just too much, so
it's been great.
Yeah, good. It was good to know that feedback. Catherine, I saw you your thing pop up. Did you have a comment or a still no?
No, I'm good.
Okay. All right. Just wanted to make sure we didn't leave you out if you were dying to jump in there.
No,
Okay.
no, I mean, yeah, I have a question.
Mhm.
About using the laser and the shockwave together.
Uh-huh.
I know you already talked about that, but can you give us a little bit more information about a protocol, or when would you use it together, and also the charges? Like, do you charge like two different modalities, or is like one charge for all?
Oh, and that will very much. Now, I am not the person in the university system to ask about charges because our structure is completely different from practice. So I will leave that for others to comment on. But I think it's probably all over the place. It just depends on how you approach that. Like personally, I combine my, we have some folks, Dr. Gale was saying that she combines, the same treatment. I actually will split because you end up doing, depending on the protocol, and again, we're going to get to this here in just a minute. Like if you are adopting the traditional bicipital tendinopathy protocol and you decide to do one treatment once a week, every third week. So you have every third week for 3 treatments. So you have about a 9-week period. I will do the off weeks. I will do that with laser. And so that's how I put it together. Personally, that's how I put it together, because I still want that pain management. I still want some of that, again, more superficial stimulation. The little bit of angiogenesis that we get at the surface level. I don't want to go quite at 3 weeks. Since then, I have started kind of bumping a lot of my protocols to weekly on shockwave. Cindy and I have had a lot of these conversations, and I'm like, okay, all right, I'll go to every week, mainly because we're kind of dropping the energy on it. So that's how I, again, kind of do what feels right for you and that patient, keeping in mind what the basic science is and what you can expect out of that modality, what seems reasonable to apply it to that animal, I think is what we have to do now, because there are 0 studies in that department.
Great.
So, so unfortunately, I just, there are no great answers to give you on that one. But again, I think it's circling back to the basic science and saying, what is a reasonable thing, how should we reasonably put this together? And then, on the charges, I just, we actually charge separately for our shockwave. I mean, then we have laser packages. And so we just kind of mix and match. And my staff hates me when it comes to all that, because I end up throwing it all together and I'm like, figure it out. And so, I thought that this was very interesting. So this is taken from, and it is well worth the read on the Human article, because it was from a group of practitioners in Spain, and in Europe they have used laser in humans much more. It's still very limited in the U.S. because of the FDA approval. There are kind of a handful of syndromes that you can use it for on the human side, and so it just, because it's not embraced by insurance or paid for by insurance, we don't see that explosion. However, they had very good evidence for a lot more on the other side of the pond than what we do. So so it was some really high level evidence for, and then we talked about that bone healing is the prime thing that it has, is really where it shines, so to speak, and where it has some of the strongest evidence for efficacy. And then coming just down through, of course, patellar tendinopathy, we've shown that nicely in dogs that are post TPLO and have that patellar inflammation, that patellar tendon inflammation, and works very nicely that on the canine side. Achilles tendinopathy, it's my go-to. I absolutely, that embraces, are the things. But then low back pain, osteoarthritis, and we're seeing, these are good levels of evidence. So I think that we are headed down the right path on it. But I thought that this was just a good thing to point out, that we're seeing some great evidence there. So finally getting down, because I want to leave enough time to discuss protocols. It is the wild west. We've all got opinions across the board here. They're all probably, just as valid, but we don't, just please recognize that we don't have the controlled the good controlled studies that we need to say. So how much, how often is the big question, right? And this also came out of the human studies, which again, I think is very worthwhile looking at. One thing that's interesting is sometimes their pulses get way up here. So they, I tend to stick down more towards around the 1,000 to 1,200 pulses. And I think, and Cindy's been beating on me to go even lower for some things that we just don't need that intensity that we think that we've always thought that we need.
In my, I don't mean to be beat a dead horse on this one, but the difference between a human being understanding pain and when you
absolutely
and the small, especially horses don't hurt much, but the small animals are so sensitive.
they are and the thing that I and part of it comes to so I used another I was military working dogs for 30 years of my life with Army Vet Corps. And so I used another machine that partly we had to sedate them because of the noise, and that the intensity on that, they would not tolerate it. And so, those are big bad dogs that will try to, to eat you when you induce that kind of pain. And so, I agree that we don't, and we're seeing the accumulating evidence that we don't need that sort of intensity in order to elicit a response. So, and you can see all of these are low intensity. So this is stuff that does not exceed about 0.15 or, about 0.1315 millijoules per millimeter squared. Higher, you got to go higher for bone. Those are the ones that you're going to get up into the 0.3, 0.4. But otherwise, these are all low intensity. So, just again, kind of keep that in mind. All right. So I just kind of, I'll look at this. Oh, I'm sorry, but let's go back. So, here, almost all of the human protocols are every 1 to 2 weeks. So I think landing somewhere in that, in that range is an appropriate, I've gotten to where I think personally 3 weeks is too much time in between, especially when we're using lower intensities. But it also depends on, if we're looking for pain, those inflammatory mediators, initially, we're going to have sort of a cyclic effect. We're going to treat, those inflammatory mediators are going to go down. We have not cured the hip dysplasia. And so we're going to have those inflammatory mediators go up. And so we have to kind of establish the rhythm of the particular animal for where they are in their, say, their osteoarthritic pain, that's secondary to some structural abnormality. And so those are ones that, I tend to, especially initially, do like the osteoarthritis ones more frequently. And then we'll go into kind of a maintenance phase and say, let us know when things start to kind of flare up again, and we'll do a tune-up. But this is, and then these were the number of treatments here that were the number of sessions. So again, most of them are sticking to 3 to 4. Some of them get up here pretty high. Our European colleagues do like a lot of treatments. They get up into those 8, 10, 12 treatment sessions. So anybody going that high? Or are you trying to kind of stick around 3 to 4?
8, no, I go more than that.
3. Okay. And sorry, it says NTP iPhone. I don't know who that is.
I was going every week just because she felt like it helped her dog, and if she didn't come, she'd go start hurting again. So I was treating weekly, like for a long time.
Okay, for arthritic joints?
Yes.
Okay, yeah. So totally appropriate, and especially if you have more advanced arthritis, then those inflammatory mediators are not going to completely go away. So they will, they'll continue. And I'm curious. So what intensity did you do? What was your setting on that?
Gosh, let's see. I'm sorry, I'm driving, so I'm kind of.
Oh, no problem. Yeah, don't don't look up anything.
I would go up to, it was her hips. It was a large dog, so I'd start off maybe at 12 and go up to 14, 16 for my intensity. At 8 for my frequency. Is that right? I can't talk in millijoules and moles and whatever.
Yeah, that's
yeah.
high. That's high.
Yeah.
But it kind of went to a tolerance, like, because I was told, you want to go as high as you can tolerate and build up to it, and then once they can't, you back off. So I don't know. But
right.
I do the same.
Yeah. Yeah. And again, just keep in mind, the interesting thing is that we're seeing that we may not actually need that sort of intensity in order to, or especially, perhaps after we get it under control, because there is, I mean, it is also well known and well shown that high intensity, so this is getting up into the 0.4, 0.5, really high, that actually can be detrimental to the tissue. And so there is more is not better. So just keep that in mind. If you're sticking below 0.2 or lower, you're probably okay. But, we're just finding that a lot of them, when we're hitting that 0.1, 0.09, 0.1, 0.15 is probably actually really going to be sufficient for what we need it to do, because we're still influencing those pathways.
What does that correlate to on our machine when we're looking at,
if you're, so that'll be like a, hang on, I've got my, it's like an 8.
Yeah, on the F7G. I think it's
On the F7. Yeah.
Yeah.
Now it's going to be different on your linear. If you what we call our linear probe, our focus line probe, the FG, whatever. Let's see.
I think.
Yeah, and if you can set your machine to actually show you when you're doing those levels that will actually. I don't work in the levels per se. I work in energy. So, yeah. Because I think it's
unfortunately, that's the new machine. So it's time to upgrade, guys. I'm joking. I'm joking.
Got it. Okay, I'm sorry.
That's we can convert in our
You have a chart.
A good thing to know. Okay, sorry, I did not realize that was yes, that would make total sense. Let's see here.
9 is 0.5, so I know that by heart.
Okay, yeah. Cindy can definitely tell you those things, because I have to admit I don't work in a in that. Yeah, so 5 to like 18 on the intensity, right? For the
7G3, you guys should be careful of when you get above 15, in my opinion. And I'm conservative. Okay. I am conservative because I don't want to get in trouble, but I would recommend for the small animals to be wary of going above 15.
Excellent. Okay.
Yeah, I usually go around 8 to 10, but we were taught when we first got the machine to go to tolerance, and if the animal wasn't showing any kind of reaction, that we were wondering if we were having any effect at all. And that's the way we were taught when we first bought the machine. Not that he's jumping out of his skin or something, but he should just, like, maybe you can tell when they start to feel it, and that's when you were getting a good effect. That was the way we were taught.
That was many years ago, and I'm happy to anybody who purchased before I started working, which was about 4 years ago. We've learned a lot and changed a lot of our recommendations. So I'm happy to jump on a Zoom or a phone call and kind of explain where we've gone with this at some point, because it's changing. We learn every day. Okay. We learn
absolutely, because that was the thought that is to kind of take it up, but we're actually seeing that we just don't need that, those again high intensity in order to influence, because again, go back to that really complicated slide, those crazy number of pathways, and we haven't even obviously figured them all out yet, that we have that effect without having to get up into that painful, number one, that painful intensity, but it also depends on tissue. Bone is different. You got to get it up a little bit higher on bone, and sometimes those you're not going to be able to, you're going to have to sedate that animal. They're not going to tolerate that. But working in soft tissue, we just don't have to have that level. So, and we're still seeing good, so this study right here, Julie Thompson and her group that came out, this was a retrospective, but almost all of these dogs were treated at the 0.1 to 0.13. 0.14 level. So they were at a low, and they all had decrease in so this was supraspinatus biceps. It all had decreased cross-sectional area showing healing. And so had improvement in the actual appearance of the tendon, still at that low intensity level. So, we are seeing the effect. So yeah, take Cindy up on her offer there, because she's definitely kind of reformed my my thoughts about how to apply this, because I was used to that power, that power house. So I think probably maybe not, and that's probably why we ended up with these every 3-week protocols initially, is because we did enough. They had to have a rest period in order to tolerate the next treatment. There's also a line of thought that, after we deliver a certain number of treatments, the big question becomes, say for tendon healing or for soft tissue healing, do we keep going? Probably not. There's a point where, that we just, we've upregulated the process, we've kickstarted the process, and then we need to give it time to continue. Now, a different approach for that versus, again, treating that arthritic joint, that disease or that syndrome that is going to continue to be pathologic. Those are ones that we have to continue. For me, it was lumbosacral, because lumbosacral is rampant in our working dogs, and so we use that as frequently as a tool for pain management for our lumbosacral affected dogs, and so we use it continuously as needed, throughout most of their working career. So I will leave this for our little brand new space there, but so I definitely, let's for the last few minutes here, and I promise not to 2 minutes, but we've had good talk, but I'm willing to stay here as long as you got questions or thoughts.
So I just want to add in, Dr. Lindsay had a good comment in the chat. Often when we get above 5 or 6 in our protocol and our intensity, so that's your 0.1 area, millijoules per millimeter squared, and we don't see any reaction, we can be missing the actual exact target.
Yeah.
And it is a key for me when I train now, that if you get to 0.1 millijoules per millimeter squared and you don't see anything, it's a time to kind of just red flag in your brain and check. Now, I'm not going to say some senior stoic dogs will never show any reaction when you're where you're at. But that is something that we try to teach now as we work with the energy. When you get to 0.1 or 0.15, no reaction, maybe try a different gel pad. Maybe think about where your angle is, a few things like that.
Right. Your depth, your and again, and I consider that the strong point of the piezo wave is that it is very precise. And so if you don't put it on, on the lesion, so to speak, you're not, you're unlikely to get that more intense or just a reaction period, because you're probably not hitting the exact area. But that to me is super important, is, again, what you're treating, what the lesion is, where you're headed for. And it just makes it easier when you're treating like an arthritic joint, because then you can just, you do your sweep, you're hitting, again, you're thinking of hitting that synovium, that connective tissue. And that's a pretty easy target. That part's easy. And you're not necessarily looking for a reaction on that. Comment here, we've been staying conservative around 0.6 to 2 or 3, which is 0.048 for tendinopathies and arthritis. Probably a little low for tendinopathies, in my opinion. I would bump it a little bit closer to that 0.08.
Luke, I know that we do start that low, and Dr. Owen does see results there, but I think she treats, it depends how many times you treat, et cetera, et cetera.
Yep.
So as you're working over your series of treatments, feel confident to go more as you go. We do recommend starting low because of the pain factor.
Yep. And again, there's that difference in intensity, the number of pulses, and what is going to be basically your total energy delivery. So keep that in mind.
Yeah, he's using more pulses also.
Yep.
I have a question, if I can.
Sure.
When I first bought my machine, and like I said, I know we all use these on ourselves, I was asking the rep about using it on hamstring issues and and humans, and he said, oh, there's a great paper on that. So I don't really know where that is. I can try to find it. But if, like, for fascia, if there's adhesions, around a muscle or if the tendons, adhesion in the tendons, muscle from a previous injury, can the shockwave machine break those down and allow them to heal properly? Because I know, like with tendons themselves, there's that whole thing where they get mangled and they can straighten out and look beautiful again. But for adhesions that are like these are causing muscle spasms and things like that, can it relieve those, or are adhesions always going to continue to form and continue to form? Does that make sense?
Sure. So it partly depends on why, are your adhesions from chronic inflammation? Are they from, scars that we have not done our scar work on? Because, as a field, we ignore scars, which, we absolutely shouldn't. So I think some things you can resolve. Others, if like, say for chronic inflammation, it's going to be an ongoing process, just like an arthritic. I would treat it like an arthritic joint that you're going to have to continue to, but I will do things like I add Adequan, I do manual, I do myofascial decompression therapy. I kind of use several things. And that's actually one of the times when because I would say shockwave for me has kind of largely replaced therapeutic ultrasound, but that is one thing I still grab for myofascial work is therapeutic ultrasound.
Okay. And I have a horse that I'm treating for myositis and the same thing, like the hamstring basically. And my understanding is that once you can feel that big lump back there and you're seeing that goose stepping, it's already become chronic. But I think it's shrinking. And I don't know. I always, I don't want to feel guilty having this owner continue to pay me to come out if I'm really not going to affect a change. But I think I saw treatment, information about treating that with the shockwave, but I don't know if I'm too late.
I think that certainly we will see it. I mean, we've seen it in the tendon studies, this one that's sitting up right now, that it actually did change that scar tissue. And so I think that you can get that effect even later, later into the scar process. If it's very, very advanced, it's going to be hard to remodel that. But Cindy?
Again, I think you do get changes, you get small changes. And sometimes it's just a matter of getting it started. As long as I know we all feel bad, especially, overcharging, over treating. In that case, we don't know a whole lot. So my answer is to consent and inform the client. Listen, this is what I'm seeing. Do you want to continue or do you want to?
So would we also do some massage maybe and what about KT taping just to kind of help encourage?
Oh, of course.
Yeah. That's that whole myofascial decompression. And
okay, gotcha. Yeah.
And I would do kind of some so we use the LymphaTouch system, which actually, and you can actually do the same thing that with cupping to produce that myofascial lift. And so that's the other tool, because it's kind of an added value for your clients to monitor is if you do have portable ultrasound it, like diagnostically ultrasound it, because you absolutely we're seeing that we do see changes in the tissue.
Cool. Okay, yeah.
On the diagnostic ultrasound, so that can give you an actual objective.
Nobody's breeding horses anymore, so I need to use that ultrasound that's just sitting
there. You go. There you go. You have your new mission for your ultrasound. So absolutely. Yeah. And if you're looking for it, which I think is great, because that's how we do gain our, grow our knowledge, is that if you have that objective data to say, hey, not only did I palpate it, but I actually saw the muscle fibers, kind of reorganize and, had the, whatever the changes that are pathologic changes and the core deficits, that those improved. That's fantastic.
Yep. Okay, cool.
Yeah, absolutely. Well, Bess, it is 6:07.
There's two questions in the chat. I don't know if you have to address them, or they can shoot me an email and I can help them out with it.
Sure. The sedation protocol preference during treatment if it's necessary. Are we talking small animal?
That I don't know, Steph, where Stephen comes from. Yes.
Okay. Because I was just getting ready to say I cannot speak for horses. So truthfully, most of the time I use just a dexmedetomidine, butorphanol, very, very light, mainly because I love the fact that I can reverse, the dexmed part. And so, and truthfully, I can't remember the last dog that I've sedated. The only time I do them sedated is if they have had other procedure. either CT'd them or we've, you know, or we've done our MRI and now we're treating their gracilis myopathy that we do them under anesthesia. But there's also an interesting observation on the human side that the ones that were shockwaved under anesthesia did not respond as well. So it makes you go,
Yep. Very
So,
interesting.
yeah.
And do you
so
do
that,
any patellas? Do you do
on the
any-
luxating patellas, I don't personally use it for luxating patellas because I think my personal view is that, of course, depending on what grade, if you get to a certain grade, you got to go to surgery for it to have, you know, a long, in order to decrease, you know, so if you have your grade 1 to 2, they're non-surgical. Managing those with therapeutic exercise, trying to strengthen those muscle imbalances, just managing, yes, for it wouldn't be wrong to use it for just for the pain part of it and some of the inflammation, but you're unlikely to change the course because it's a structural abnormality.
Yeah, if it's a minor one, I have seen, but going both at the patella and through the muscle, because you got to get the muscle to relax also in some, so it's not as simple.
And I could see where you might get some lateral, with reorganization of that tissue, you might get some lateral tightening that might help like a grade 1. We just don't have that evidence. So, you know, as far as any study. So, you know, if it's, you know, if it's working for you and above all, do no harm, right? When we're trying these things, do no harm. But if you feel like you're getting good response, and I think that that's a reasonable, you know, reasonable thing.
If they're major, it's a surgical situation.
Yeah.
For sure.
Yeah.
Do you use Librela with it, with Shockwave? And then we'll let you go because it's.
Oh yeah, so Librela is a whole new conversation. We do, yeah. In other words, I have Shockwave dogs that are on Librela. So that's the short answer. You know, do screen your Librela patients appropriately. We still have a lot to know about Librela. To see if we're, you know, there's been some reports on the surgery side, not on the internal medicine sports side, about this rapid progression of osteoarthritis, but there's some potential suggestion. We do not know the connection for dogs that have had joint surgery that have basically a collapse of that joint and severe osteoarthritis onset in a short period of time that is somewhat suggestive of what they saw in humans. It has only been on the surgery side, so I can't tell you more than that. It's a very, very few, you know, like 4 cases. And so just continue to watch the reports on Librela as we gather more information, as we give more doses of it. But I do, in those patients that I have screened closely and I have a good conversation with the owner, I use it. And then I use laser, all the other modalities, you know, along with it.
Well, I'm gonna let Dr. Pierce get out of her workplace for a little while.
No problem. No problem.
And say thank you for everything. And you guys, I will post these 2 papers also. I sent via email. I will post them on our Facebook users group for anybody else who did not receive them or for some reason missed on that. This will also be posted both on the website, and then I'll send a link on the Facebook group. And guys, I really appreciate your time and effort. We don't know a lot, but please keep to the science. That's our biggest. I think that's what Dr. Pierce and I are most concerned about, is that we do understand the basis of the science. If it's overkill for anybody, feel free to reach out. I'm happy to share anything I can. All right. Thank you very much.
Absolutely. Thank you so much.
Thank you, Dr. Pierce. It was wonderful. I appreciate it.
You bet. Yep.
Good night, everybody.
Thank you. Bye.
Good night.